Hi, this is Dr. Mahadevan, and welcome to the Advanced Airway Discussion Case, Part 1. And let's look at our two cases for today.
Get it out of here. Let's intubate him. Carter, why don't you jump in here? Me?
7.5?
You've seen about 50 of these by now, right? Okay.
All right, so Carter has been asked to intubate this patient. What is a mnemonic to help remember the equipment that you need prior to endotracheal intubation? So our first question is, what is the equipment, what is the mnemonic for the equipment that you need to perform endotracheal intubation?
Okay. Visualize the vocal cords and pass the tube through them. Okay. Stay away from that esophagus. Good.
I got it.
Nice work, Carter.
OR's waiting. What do we got?
Tube's in, let's go.
So the tube's in, and now they're whisking the patient off to the operating room, but there are a few things that you always want to do after intubating a patient. So what should have been done immediately after intubating the patient? What are the things that we should be doing? Let's move on to our next case. This is a 37-year-old male brought in from the site of an explosion. He's got a laceration to the inside of his mouth and neck pain. And as you can see, he is spitting up blood and holding the left side of his face because of pain there. So let's take a look.
Get a facial fracture, you shouldn't talk.
Neela Brenner, I need you with Bardelli in 2. We're on it.
1, 2, 3.
Trauma panel, chest, facial series, and tip fib.
That's your 93. Ready?
Open up, buddy.
I need a gram of Ansef and 100 of Gent.
Some jelly for the belly. Small lac to the oropharynx.
So facial fracture, low oxygen saturation, small laceration to the oropharynx. And our question is, how can intraoral bleeding complicate airway management, and what can we do about it?
For HIV and hepatitis.
Pulse ox down to 88.
Put him on 100%. Pneumothorax on the chest x-ray?
No diffuse bilateral contusions.
Last lung.
Shockwave caused bleeding and bruising throughout the chest.
I know.
Might get worse before it gets better.
Look at the numbered breather.
So this patient has a low oxygen saturation, this trauma patient. What is your differential diagnosis in a patient with a low oxygen saturation? The differential diagnosis in trauma patients with low oxygen saturations. And the doctor mentioned blast lung. So what are the pulmonary complications of a blast injury?
Breath sounds.
Pulse ox is dropping.
Damaged alveoli are filling with fluid.
We need to talk about intubation, Greg.
He's getting worse, and they're talking about intubation. What are the indications for intubating a trauma patient? What are the reasons that you would intubate a trauma patient? And also, why are they intubating this particular patient? What's going on with the patient that mandates that they consider intubation?
You see the cords.
Too much blood.
What about cricoid?
Anatomy's distorted. Now you're making it worse.
Pulse ox down to 80.
Things are getting worse. The pulse ox has dropped to 80. It's getting tense. Should he just try to pass the endotracheal tube even though he can't see anything because of all the blood? And if not, what should he consider next?
All right, that's enough. Bag him up.
You do this, Archie. You're better at it. Here, come on.
Open up a 7-0 and a bougie.
So they can't see the vocal cords, and they're trying their best to do so. So how could you as an assistant help improve visualization of the vocal cords for the endoscopist is the first question. And they mentioned a bougie. What is a bougie and how might it help in this particular situation? A bougie.
Yeah, see the epiglottis? Yeah, as far as I got too. Everything's pushed to the
Here's
right.
my hand as a guide, and I'll hold when you see the cord.
That's drifting down.
Forget it. There's no way.
You want to try the bougie?
I can't see the larynx.
Fiber optics here.
Right, I'll set it up.
Too much blood for that.
You want to try again?
He needs oxygen.
So a lot of bleeding and the airway structures are pushed to the right. So why might that be? Why are the airway structures pushed to the right? And again, in this particular circumstance now, what should the doctor do?
He needs oxygen. He needs a crike.
We could try to go
I
right.
said we're criking.
No crike tray.
Check the hall.
Socks is in the 70s.
Okay, forget the tray. I need an 11 blade and a Shiley.
All right, I got a 10 blade here.
Where the hell are the Shileys?
Run a VTAC. Open the crash cart.
Sam, you have bandage scissors?
Yeah.
Get over here.
Morris, what are you doing? Bag him.
Morris.
What are you doing?
Morris!
Hey!
Okay, cut the drip chamber right here. Bag him up.
Good chest rise. What the hell was that?
Ducks come out.
All right. All right.
You still need a crike tray?
So our next question, our final question is, would this improvised cricothyrotomy actually work? And what are some other strategies that you might employ in this particular situation? I hope you'd enjoy these very interesting cases. This is Advanced Airway Discussion Case, Part 1.